and 1 minute to go. And thank you, Professor Nadeep. It's very early in Alabama now. It's maybe 6 a.m. Quite early.
Yeah, it is early morning in here.
Thank you for coming. Okay, it's time. So yeah, good morning and good evenings. This is the 119th International Chang Craniofacial Webinar, ICC webinar, and I am Dr. P.Y. Cho. Today, I will moderate this webinar with my partner, Dr. Junior Tu and Dr. Pryor. Today, we are so happy to invite Professor Cha from Yonsei University, Korea. Later, Dr. Pryor will introduce our speaker, Professor Cha. However, I would like to introduce our three very valuable and important panelists. The first one is Professor Nadeep Busri. Professor Nadeep Busri is an assistant professor of orthodontics at the University of Alabama at Birmingham. With over a decade of international experience, his expertise uniquely integrates digital manufacturing with complex craniofacial care. Recognized as a rising star by the World Federation of Orthodontists, Dr. Busri has published extensive research on cleft and palate outcomes and craniovertebral biomechanics. Let's welcome Professor Nadeep. And our second panelist is Professor Waruta Kasarsan from Thailand. Professor Waruta is an oral and maxillofacial surgeon at the Mahidol University in Bangkok, Thailand, a diplomat of the Thai Board of the Oral Maxillofacial Surgery. She specialized in advanced virtual surgical planning and digital simulation workflow for complex reconstruction. Dr. Waruta is an pioneer in in-house patient-specific cutting guides and fibula free flap reconstruction. Her research focused on OGS in the navigation systems with numerous publications on Thai craniofacial morphology. Welcome, Professor Waruta. Our third panelist is Professor Alan Wen-Ching Ko. Professor Ko is a distinguished professor and the vice chairman of the Department of Dentistry at Chang Memorial Hospital in Taiwan, with advanced training from the University of Illinois at Chicago. She specialized in surgical orthodontics, craniofacial anomaly, and 3D image simulation. As the editor-in-chief of the Taiwanese Journal of Orthodontics, Professor Ko has authored over 100 journal articles focusing on OGS, cleft lip and palate treatment, and obstructive sleep apnea. Her pioneering research significantly advanced clinical outcome in complex craniofacial care. Let's welcome these three important and key panelists today, and then followed by Pryor's introduction for our speaker. Pryor, please.
Okay, hi everyone. My name is Pierre. I hope you may remember me, and I'm very happy to see all of you at ICC webinar again. And today is our highest honor to welcome Professor Jung Sha to join our ICC webinar. And I would like to introduce Professor Sha first. Professor Shah is a distinguished world-renowned orthodontist. He currently works as a professor at Departments of Orthodontics and the Vice Dean of Academic Affairs at Yonsei University College of Dentistry. Professor Shah has dedicated his career to advanced orthodontic science and practice. His expertise is highlighted by his role as a visiting professor at prestigious institutions, including the Universities of Southern California and Stanford University. As a prominent figure in the orthodontics community, he served as a Secretary General of the Korean Associations of Orthodontics, and hold leadership positions in various associations. Professor Shah's research focuses on cutting-edge orthodontics treatment, utilizing CAD/CAM technology, 3D printing, and AI application in orthodontics. He has published numerous papers in esteemed journals, contributing significantly to the fields of scale and courage, digital orthodontics, and biomaterials. He also an international speaker and delivered the presentation worldwide for advancing the knowledge in orthodontics and digital dentistry. So now it's time for Professor Shah's presentations on the topics of presurgical orthodontics, guided by 3D surgical simulation in facial asymmetry patients. Welcome, Professor Jung Shah.
Yeah, thank you for kind introduction. Very long introduction. And yeah, I would like to express my sincere gratitude for the invitation in this wonderful seminar. And good morning and good evenings. And it's my great honor to be here. And actually, I know the Chang's hospital is very well known for the surgical kind of study. And actually, the surgery is actually, I'm very interested, but this presentation is my first presentation. So I'm just to introduce my protocol in this seminar with you. So today I'm focused on free surgical orthodontics guided by 3D surgical simulations, especially in the facial asymmetry patients. So I'll introduce our digital-driven orthodontic treatment in my departments. So nowadays we scan all the digital model from the initial patients, especially deformity patients. So we take scanning, intraoral scanning, and the CBCT. So with the help of two digital data, we can have an initial kind of 3D diagnosis using the 3D software. So now we can do model analysis. At the same time, we can do 3D analysis. So here's the flow for the surgical patients. First, we are doing diagnostics virtual simulation. This is not a comprehensive virtual simulation. We just apply surgical simulation before orthodontic treatment. So I call it the diagnostic virtual simulation. So here is the first steps. And secondly, after pre-orthodontic treatments, we are ready for the comprehensive virtual surgical simulation. This is must be very precise. And finally, we can fabricate this surgical vapor and for the complete surgical treatments. So today, actually, I want to focus on the first one, diagnostic virtual simulation. So let's see the importance of the surgical simulations. We all here we know about the benefit of the simulation using 3D software. First, we can get a precise and accurate treatment outcome because we can measure the quantitatively the amount of deformity before treatments and before surgery. So we can guarantee predicted outcomes because we can visualize the final skeletal symmetry. So also we can reduce operation time. And in some cases, we can apply this software for the fabrication of the customized hardware, such as patient-specific implants. So I know those three panels already well known for this field of the treatments. So we are only focused on pre-treatments, pre-surgical orthodontic treatment as an orthodontist. So especially we try to some decompensations during pre-surgical treatments, such as AP corrections and transverse corrections. And this is helpful to maximize skeletal symmetry after surgery. So how about outcomes of the facial asymmetry patient after surgery? Here is some report from the other countries, especially one study from the Chang hospitals, and there's a various kind of the chin point deviations after surgical corrections from the 1.3 millimeter. Most of case within 3 millimeter of the chin point deviations, but 3 millimeter deviation, I think we can accept is a clinical threshold, but when you look at the volume discrepancy between deviated and non-deviated side, I think some cases a significant asymmetry we can see after surgical operation. So one of the cases, this is 2024 from the Chang hospital. They found that they tried to analyze patients' symmetry after surgery from the AI. And because we have a lot of human error to define the midline, so they applied AI system. So from their the patient data, they found that 50% their symmetry improved after surgery. So 50% is improvements, is like a mean value, because their range is pretty wide, from 16% to 86%, which means some patients still has a asymmetry even after surgery. So many cases we think are stable, but we have to accept there must be some within range of the asymmetry after surgery. So we are concerned about the residual asymmetry after orthodontic surgery. Why it happens? There's a major reasons already reported. First is a hard tissue problem, and second is a soft tissue problem. The first thing is the intrinsic bone morphology. Patients, their mandibular or maxillary bodies, there's high discrepancy in their structure. We have to expect some asymmetry after surgery because very complex cases. So in that cases, we are very struggling to the decompensations before the surgery, which is means insufficient decompensations. And there's other issues such as soft tissue imbalance because of the soft tissue thicknesses between non-deviated and deviated side. So those are many reasons causing asymmetry after surgery. So as an orthodontist, we have to build up the strategic dental alveolar decompensations for the facial asymmetry. We know that the mandibular asymmetry can be classified by 3 types: the loading type and translation type, and yawing type. So when you see the figure of the skeleton, we can see these patients. We can see the complex of the asymmetry, because on the maxilla we can see lowerings and the mandible shift to the right side because of translations and yawing of the mandible. So many papers suggest that targeted dental alveolar decompensation based on their asymmetry type. But I think those 3 types of the asymmetries always combine. So it's difficult to define in some cases. So we have to decide the target tools for the decompensation before the treatment. So here.
Yes, Professor Cha.
Yeah.
Excuse me. Could you extend your screen to full screen? Yeah.
Okay, this
Yeah,
is
thank you. This is a presenter's model. Yes.
This is presenter model.
Yeah. Thank you.
I'm sorry. How can, okay, I'll try.
Yes, screen. Mhm.
No.
Yeah. I show.
Okay. How to make it opposite?
Or Professor Cha, would it be possible if you end the slide first and then change
Okay.
reopen it up with the full screen mode? Yeah, this is perfect.
Got it. Yes. Perfect.
Okay.
Thank you.
Thank you.
Yeah, I'm sorry. Okay. Yeah. So let me start again. So far we are focused on virtual simulations just before surgery. So to fabricate the surgical wafer. But in my presentations, I just focus on before orthodontic treatment because as orthodontics, we have a focus on decompensation. So we have to decide of the target tools for the decompensations. So for the getting the goal, I think instead of the 2D STO for the diagnosis, I recommend replace this 2D STO by 3D pre-surgical diagnostic simulation combined with the CBCT and digital model. So I think in my presentation, we may confused. My topic is a comprehensive surgical simulation for the surgical simulation, but in my presentations, I'm talking about diagnostic surgical simulations for the pre-surgical orthodontic treatments. So I show you some cases which I apply this protocol for the targeting our decompensations goal. So I can explain my protocol for each cases. So here's a 21-year-old female. She complained about facial asymmetries. And here we can see the anterior crossed by right side and midline deviations. And the patient showed the class 3 molar relationships. She had the mandibular asymmetries, or also she had the maxillary cantings, and mandible was deviated to the right side around the 4.7 millimeter. And she was class 3 tendency, high angle. And from the 3D analysis, we found that the different lens heights and different body ranks, and also the patient had maxillary cantings and also mandible yawing around 1.8 degree. So here, this is a protocol for pre-surgical 3D simulations for the diagnosis. First, we make the composite model of the digital model and CBC data. You just apply the digital model to the patient's skeleton. And then we can try some surgical simulation. Here is a surgical simulation for the optimal occlusions. This means we try to make midline and molar relationships and vocal object. So we are focused on occlusions. So when you make the purple occlusion, we can see the change of the mandible. So this is a simulation result after optimal occlusions. So after simulations, we can get optimal occlusions, but when you see the mandibular body, still mandible debit to the right side. Also, the mandibular yawing was not corrected completely. So in this case, if I correct these patients surgically, for example,
Excuse me, Professor Cha.
yeah,
The slide is not advanced. It's a stop in the only 5-phase slide.
really?
Yeah, we can just we can try out and in again. Yeah, thank you.
Can you see? Can you see? Can you see the change of slide?
No.
It's like a 5-phase of the patient, like with the astrophysics
Okay.
3D slides. Yeah.
Okay.
Maybe you off again and like go in for the full screen.
Okay. Just hold on.
Oh. Ah.
Can you see?
Yeah.
Perfect, perfect. Yes.
Okay. So this patient's 21, and the mandibular asymmetry is around the 4.7 debit to the right sides. And I just suggest the two surgical simulations. So here is a composite model between skeleton and digital model. So the reason I apply the digital models to CBCT, we can clearly see the occlusion in detail. So after you finish the composite model of the digital model combined with the CBCT data, we have some trial surgical simulation. This is a try to make optimal occlusions. You can see midline on and the class 1 canine and molar relationships and proper buccal object on both sides. So we try to make the perfect occlusion. Then we can see the change of the skeleton by surgical simulation. So here, after surgery, we can see still mandibular chin point was deviated to the right side, and still mandibular yaw was not corrected completely. So in this case, we have to do some additional surgical compensation, such as angle shavings or shifting chin genioplasty. So here's the second options. We can do surgical simulations for the optimal skeletal symmetry. So we don't mind of the occlusions. This case, we just focus on symmetry on the skeleton. So here we correct the mandibular yawing. So try to correct the asymmetries. So we achieve the perfect symmetry in this case. So after correcting the mandibular asymmetry, then we can see the occlusions. So we can see the final occlusion of the digital model. So look at the midline deviations. Midline deviate to the left side, and look at the molar relationship, at classic molar relations on the right side, and the shallow object on the left side, on the buccal posterior occlusions. So from the change of skeleton, we can expect the change of occlusion after surgery. So we can decide the targets tools for the proper decompensation. For example, this case we have to do midline corrections. For example, we need to distalize right segment to the right side, and also we have to increase buccal objects for the left side during the pre-surgical orthodontic treatments. So based on this model, we can make a plan for the decompensations protocol. So the patients showed a little bit protrusive ribs. So in this case, we decide to distalize of the maxillary dentitions, and the mandible, we decide to distalize of the light segments to correct the midline for achieve the symmetry after surgery. So we put the 2 mini screw on the mandible, the right side, and the distalization of the lower dentitions. So here's a protocol. Maxillary distalizations on the mandible, we correct the lower dentition of the right side. And here's before the surgery. So we try to make a proper decompensations by distalizations around the 2 millimeter of the maxillar and the lower right segments around the 2.8 millimeter. So make more worst midline deviations. So after surgical corrections, we can achieve the more symmetric mandible. Here is after treatments, the change of skeleton. Yeah, this is a comparison of the surgical simulations and the real outcome. Left first is we just try the surgical simulation by optimal occlusions, but we correct it by optimal skeletal symmetry. So by means, during this pre-surgical simulation, we decide the target's tooth for the decompensations, and right's images is after surgery. So this case, if you choose improper decompensation protocol, it may trim point deviation remain. So in this case, very critical to distalize lower mandibular posterior segment to the right side, so we can achieve the symmetry. So here is after surgery and the change of profile. Yeah, this is 2-year retentions. And you can see the stable symmetry after surgery and 2 years later. And can you see the second case? Because I using animation.
No, right now you exited the slideshow.
So you cannot see, right?
No. Right now you're not sharing your screen actually.
It was inactivated. Okay.
Yes.
Okay, can you see?
Yes, we
Good.
can see the
Okay. Yeah, second case is hemifacial microsomia, very severe mandibular asymmetry, 21-year-old. And he already had a mandibular destruction osteogenesis before. And he complained about mandibular asymmetry and anterior crossbite. So yeah, he had a class 3 and high angle. And chin point deviate to the left side more than 12 millimeter, very severe. And we can see the maxillary canting more than 10 millimeter. So from the 3D analysis, we can see the high discrepancy of the lam's height around 10 millimeter, and body length also maxillary canting. Also, we can see the mandibular yawing around the 12 degree. So let me show the procedure for the diagnostic surgical simulations. So making the composite model combined with the digital model and skeletal. And then we try to make optimal occlusions, just optimal occlusion after correction of the maxillary canting. So in this case, if you just surgery without any decompensation, we can expect that kind of the change of the mandible. There's still yawing on the mandible gets severe. Also, chin point is still deviate to the left side more than 5 millimeter. So in this case, we have to do something for the decompensation, but how to do decompensation in this case? So this is a very, very good way to see our target dentition for the decompensation. We correct the mandible for the additional yawing, also additional lowering. We did a lowering and we did also yaw correction. Then in this case, after surgical simulation, we can clearly see the change of the occlusion. This is the changes. We can see the overlapping of the occlusion of the right side. You can see clearly. So maybe we have to do more impactions of the macular, but I think we can more intrusion of the molar on the light segment in this case to improve the symmetry. So finally, even though if you correct this patient by lowering the yawings, we maybe expect a shifting of the genius because of remaining asymmetry of the chin points. So here's a treatment protocol. In this case, we correct more rolling and yawing control by presurgical orthodontic treatments. So we focus on the intrusion of the molar on the right segment, upper and lower. So we put the 2 minuscule on the right segment of the maxillar and the mandible, and we try to active intrusion of the molar. So here is a procedure. We did some expansions, and we try to intrusion of right segments. So we try to make opens on the right, and we keep the space with the resin blocks on the posterior molar. So we try to make the space right segment as we can. At the same time, we make the some proper overjet for the presurgical orthodontic treatments on both sides using criss-cross elastic. So here is a treatment's outcome after intrusions. So molar intrusion around 2 millimeter, upper and lower, but there's some tipping of the lower dentition during the intrusion. So this is after surgical corrections. And after surgical corrections, we can see the chin points was the deviation was corrected. And yeah, we did some additional surgery after surgical operations. And here's change of the profile. And there's slightly chin point deviation remain around 2 millimeter because the patient has severe mandibular asymmetry. And this is before treatments. Here is the final. Yeah, the patient has a soft tissue deficiency in the left side. And also mandibular body is very narrow. So we use the Medipore for augmentation of the soft tissues. We try to make the symmetry with the help of additional surgery. So this is after debonding. We can clearly see the improvement of the facial asymmetry. And here's the profile changes. So those first and second cases, we show that first case, we try to modify midline and we try to transverse control. And second case, we focus on vertical control for the improving the facial asymmetry. And the third case is we try to reshaping arch form and transverse control by for the better symmetry after surgery. So the patients already had orthodontic treatments, and because of the rate growth, the mandibular asymmetries is getting worse, and now he wanted to get a surgery. So he visited my clinics, long face and class 3, and the chin point was deviated, and midline deviated to the right side around 3 millimeters, and class 3 patients hyperdivergent. How about skeletal characteristic? Lamus phi is really similar, but body length is much larger on the left side, and also there's maxillary canting. So left side downs around 2 millimeters, and also we can see the mandibular yawing. The chin point deviated to 7.2 millimeter to the right side. So this patient is yaw and transverse problem, the mandibular body. So because of the asymmetries, maxillary dentition was fully compensated. Look at the asymmetric molar width. Right side segment is much wider than the left side. So if you correct this patient by surgical approach, you have to do from decompensation properly. We have to do asymmetry expansion of the left side, for example. So also we have to decompensations for the posterior segments. So how to deal with these patients? This is a composite model combined with digital model and CVCT for the initial stage. So in this case, we can do surgical corrections first. So this is a surgical simulation for the optimal surgical symmetry. At the time, I'm sorry. This is a kind of surgical simulation for the optimal occlusion, based on optimal occlusion. We try to make midline corrections and make a class 1 canine and molar relationships and the proper posterior buccal objects. Then we can see the change of correction of the mandible. Despite the perfect occlusion, we can see the mandibular yawing get worse. So we think we tried to do some proper decompensation to correct the mandibular deviation in this case, which means we need to some transverse control. Also, we need to reshape the archiform for the correction of the asymmetry. So this is surgical simulations by optimal skeletal symmetry. We need to additional shift of the mandible to the left side, and we also did some yaw control of the mandible to achieve symmetry of the mandible. Here, after surgical correction, we can see midline deviation on the incisor. At the same time, we can see the different buccal object. Right side is large buccal objects. Left side is very, very shallow object. So in this case, we need to do some correction of midline. At the same time, we do some try to correct the different inclination of the molar area, posterior area. And how to deal with, in this case, the first focus on transverse control, because mandibular body need to shift to the left side to achieve the symmetry of the chin point. So this case, I used the mini screw to correction of the discrepancy of the molar width of the maxilla. So we try to push the part to the left side for the proper decompensation, which means reshaping archiform. So maxillar, we try to make the dentition to the left side. And at the same time, the patient wear the crisscross elastic to proper object after surgery. So we increase buccal object of the left side efficiently. This is a change of the dentition during the decompensation. We superimposition of the model so we can see the upper dentitions. Right segment is constricted and left segmented or expanded to the left side. This is before surgery. This is a comprehensive surgical simulation. So this is after surgery and the final outcome. After surgery, we can get a symmetric mandible. And the skeleton class 1 was relieved. And we reduced the facial height by impaction of the maxilla and the change of profile. So I showed the last case for the strategic decompensations by surgical simulations. He's a 28-year-old male and complaint was mandibular asymmetry. Yeah, anterior crossbite and class 3 molar relationships. Yeah, mandibular dentition was compensated to the left side. Class 3 and low angle. Yeah, mandibular debit to the right side, the 6 millimeter. And we can see the maxillary cantings, left side down, around the 2 millimeter. So here's a 3D analysis. So from this case, maxillary dentitions also shift to the right side, around 2.5 millimeter. And limus height, body length was different. And also we can see maxillary canting. This is a complex case combined with translational and yaw and lolling dominance. So mentum debit to the right side more than 8 millimeter. So severe class 3 cases with the mandibular asymmetry. So this case, I skipped the surgical simulation for the optimal occlusion. Just I show the surgical simulations for the optimal symmetry. We just correction of the mandible after correction of the maxillary canting and the midline shift. We just matched the mandible to the maxilla, but at the same time we correct the yaw control, achieving the mandibular symmetry. But still, we have to see a different mandibular body on the right side. Maybe we expect some shaving after surgery. And left side, we can see also those left side, the body was still augmented compared to right side. So after surgical approach, we can expect some additional shaving in this area. So look at the occlusions. We can see after surgical simulations, we can see change of occlusions, midline debit to the right side. So we have to do lower dentition to the right side during the pre-surgical orthodontic treatments. At the same time, we have to correct the buccal object. So we have to use crisscross elastic. So I try to move lower dentition to the right side to make a proper arch form. So this case, we try to mandibular dentition for the rotated to right side. So we put the 2 mini screw, both left and right side. So we put the 2 mini screw. Right side, we just put the mini screw on the buccal shelf for the distalizations. On the left side, we put the mini screw to pushing the first, the dentitions. It tried to midline move to right sides. So this case, we can increase the midline discrepancy during pre-orthodontic surgical procedure. And this is before surgery. We can also see the proper buccal overjet, change of buccal overjet for the surgical corrections. And this is after surgery. Actually, after surgery, we already mentioned the mandibular body, the volume of the mandibular body is different. So we did some cortex osteotomy, and we did some body shaving on the right side. And we tried to make the perfect symmetry on the mandible by yaw control. Look at the occlusions. This is change of occlusions. And here's the final debondings. So the change of skeleton. Yeah, after surgery. After debonding, we see there's some lip canting. I try to make the patient exercise his smile. And after 3 months, he still try, but I think we cannot recover fully the patient of the lip cantings, but it will be a little bit improved by his practice. So after debonding, I try to superimpose of the mandibular change of mandibular dentition. So mandibular dentitions is moved, rotate to the right side. And during the pre-surgical orthodontic treatments, lower dentition was expanded and left dentition was constricted, which is really helpful for the yaw controls, yaw corrections for the surgical treatments in this case. So I try to show some cases to achieving the symmetry with the help of the virtual simulation before orthodontic treatment. So I'm doing some summarize my presentations. So first, I suggest try to make a composite model with the virtual models and CVCT. So prepare the accurate dental alveolar decompensation strategies through the fusion of CVCT data and digital composite model. And it is easily visualized the relationships between dentition and basal bone. So for the surgical simulations, first, I can summarize by this protocol. First, we just simply correct the maxillary alignments with the canting corrections. So we establish the maxillar dental midline relative to the mid-sagittal plane and resolve the ocular cantings through the vertical control. After maxillary corrections, we perform the lower adjustment of the mandible to the corrected maxillar. And at the same time, we did a precise yaw control to achieve optimal skeletal symmetry. After achieving the skeletal symmetry, we can decide targeted decompensation plan by this procedure. So look at the occlusion. After optimized surgical simulation, we can assess midline and molar relationships and vocal overjets. At the same time, we can ensure occlusal contact and overlappings to validate low control of the mandible. And also we need to decide the reshaping arch form based on the geometric midline. Here's the conclusions. 3D diagnostic surgical simulations can determine the optimal teeth position for effective preoperative orthodontic treatments. And strategic preoperative ortho treatment can enhance facial symmetry, ultimately optimizing surgical outcome. But we have still limitation because we need further study, because we need to validate if actual tooth movements meets the simulated target goals. So I'm applying this protocol around 4 years ago, and now I'm getting some outcome. So we compare our target tooth movements with the actual tooth movements, and I think pretty soon we can get some quantitative outcome from this protocol. So thank you for your attention. In my presentation for the surgical simulation, I apply in vivo 3D images. So if I have additional time, maybe we can discuss about some surgical simulation with this software at the next time. So thank you for your kind attention. So I'm very sorry for my technical problem. I'm very not good at the Zoom presentation at this time. Sorry about that. Yeah.
Thank you, Professor Cha, for the excellent presentation and also for showing us such a thorough explanation of your surgical methods and process. So at this time, I'd like to invite our panelists for some panel discussion. And the first panelist that I'd like to invite is Professor Ko. Professor?
Professor Cha, thanks for your very nice, clear presentation showing the 3D diagnostic surgical simulation that has shifted pre-surgical orthodontics toward more proactive outcome-based planning, especially face asymmetry cases. And we have a very different approach to the surgery first, to the surgical cases. In Chang, we do a lot of surgery first approach, even in face asymmetry. And I think our concepts is a little bit different. You do pre-surgical decompensation a lot and try to precisely match your decompensation predict after surgery. And for us, we do decompensation after surgery. So when we set up our occlusions, we set up the occlusion based on the basal bone. For example, for the asymmetry cases, they always have transverse decompensation. So we will make one side fit and one side large overjet. If we need some of the molar torque control, and we will leave a little bit posterior open by, help us to do some of the molar playing. So I think we have a very different kinds of approach. And I want to ask your comment that in your opinion, you use this kind of sophisticated 3D simulation and eventually redefine the traditional sequence of pre-surgical orthodontics. And would you, based on your 3D technique, would you challenge more about less pre-surgical ortho instead of this complicated pre-surgical ortho? Yeah.
Thank you for your advice. Yeah, our department also surgery first many cases. But for me, in the Yonsei University, we only doing the ivory arrow instead of SS arrow.
Oh,
So
okay.
ivory arrow is just no fixations, no
okay.
references,
Okay.
but it's healing fast, by physical exercise. We just starting the mastication after 3 weeks. very
Okay.
fast, and no TMD symptom most of case.
Mhm.
And there's a lot of benefits. I know there's also critics, but in these situations, surgery first with the asymmetry is very dangerous from some cases because there's no fixations. It's very unstable by only exercise. So we have to make the patient wear the splint more than 2 or 3 months after surgery. It's very discomfort for the patient. So I did some surgery first, but for the patient with the severe mandibular asymmetry, I prefer to some kind of the ortho treatment first and the surgery. So my protocol exactly as you advise. We do some surgery first by simulation, right? Surgery first with the software. So 3D software, we just surgery first and see and decide our target decompensate tooth, right? So it's very similar, but just opposite. So you're right. Sometimes it's very struggling for the decompensation because surgery first, we can make the space both for the posterior side, but in my cases, we have to bite open, right? With the posterior bite block or other appliances. This is a little bit discomfort for patient functions and mastifications. So I agree with your opinions, and but in our hospital, we have more point on the IVL surgery. So I don't know
Okay.
why they don't try the SSR for the asymmetry patient.
Okay.
Yeah.
Yeah. And a second question, do you do overcorrection for the surgery first cases, for the symmetry cases? Overcorrection. And how much you do the overcorrection if you do that?
You mean the overcorrection, surgical correction, or pre-orthodontic treatment correction?
Both.
Both, right.
Both, yes.
Right. Honestly, yeah, we try to overcorrections as orthodontists, but sometimes we don't know it is enough for the overcorrection or not. We just clearly see after surgery, right? So yes, so in this case, actually we have a time limit, we have time limit. Most of cases 22-year-old, they only can have a surgery during the vacation. So we have a timeline, actually, timeline. So we try to overcorrect, but some cases we don't know is fully. But by surgical simulation before orthodontic treatment, we know that this is very essential for overcorrection or not. Then we have to ask patients, we need a more longer decompensations period. So we just persuade them, accept our advice. So most case, we overcorrect. But the surgical corrections are only significant severe class 3 or asymmetry surgeon they plan, but most of case they don't overcorrect surgically. So yeah.
Okay. And last question. In the cases with asymmetric arch form in asymmetry, would your surgeon do the segmental osteotomy to change the arch form to help to better achieve the facial outcome by this kind of modification? Yeah.
This is a challenging idea. How about your school, your hospital? You're doing some total osteotomy for the reshaping of the arch form?
Especially in the upper, because you know that in asymmetry cases, some of the side they were kind of inward, so the arch form will be narrower. And if we are going to shifting our mandible toward that side, and it will be kicked by this inward a line of arch form. So we will kind of prepare a little bit space and do a segmental osteotomy to our our movement of the maxillary arch, so allowed our mandible to shifting to the center. Sometimes we will do that. Yeah.
Very nice. I think you better to present your cases in my hospital, you know. I think it's very time. Yeah, in my case, I read it's time consuming for some correction,
Yeah.
transverse correction. Yeah,
Yes.
because of always bite opening. So it's struggling to correction of the molar unilateral expansions or unilateral constriction is very limited for the pre-surgical treatment. So in this case, I never tried osteotomy for the efficient decompensations. So your idea is very good. And yeah, if you have the kind of cases, it'll be very nice to read it. Right. Thank you.
Thank you, Professor Ko. Next, I'd like to invite our next panelist, Professor Navdeep.
Hi, Nadi. Nice to
Hi,
meet you.
Dr. I think Dr. Ko already took most of the questions that I have. I mean, I'm also a lot of Chang, and also Dr. Ko being my mentor, I fairly agree with her. You know, before, like when I went there for training, 5, 10, 15 years ago, surgery first was like you could only do 30 to 40% cases by surgery first. There was very strict criteria and stuff. But as the confidence built it up, I think surgery first really needs a lot of future vision and developing that three-dimensional mindset of where the dentition and the holistic soft tissue is going to be after you've done the surgery, and then you do the orthodontics. But my question to you would be, since you do pre-surgical orthodontics, I would like to know what is the timeline that you usually look at to actually make a decision that you want to do pre-surgical orthodontics first, because in a lot of our cases where we go for surgery first options, we also look at the burnout for the patient. That is the primary reason why we moved to surgery first, because pre-surgical orthodontics leads to a lot of burnout for the patients, and they get tired of all that. Whereas when we are going for surgery first for most of the cases, it actually improves the chances of them to work with us more on their correction of their occlusion. And it also affects their psychological and social benefits are there. So what is the timeline that we're looking at for pre-surgical orthodontic cases in your cases that you presented, like 6 months or 9 months?
Yeah, right. Yeah, it depending on the state of compensation of the dentition, right? If the severe case, especially mandibular asymmetry, we need more time to change of inclination of the molar. So such cases at least more than 1 year, 1 year. So I start in the winter, and most of surgery, after next summer and next winter, right? So 1 year. So yeah.
So it's the pre-surgical ortho, and then surgery, and then a bit of post-surgical orthodontics, I guess.
Yes. So most of cases around 2 years after surgery. It's very classic period, So how about your cases? I just wonder, the mandibular asymmetry patients, it's much faster, I know, after surgery. I'm only doing the surgery first, like a minimum mandibular asymmetry cases, because our surgery is no fixation on the mandible. So patient is struggling to correct the change of their dentitions, and this is why. So how about your cases? Mandibular asymmetry case for the more than 5 to 6 millimeter? How much the treatment was shortened just before and after? Yeah.
Right. Well, one thing that surgery first does is does very well in helping an orthodontist is the RAP phenomena, rapid acceleratory phenomena. So
Yeah,
after
RAP. Yeah.
the surgery, the dental movements are pretty fast. And guess what? I remember you saying that, the patient end up with a very big open bite in the posterior. Believe me, when I went there for my training in Chang and I saw Dr. Eric's cases or Ko's cases with those, 10 millimeter or more of posterior open bites, my eyes were like almost popping. I was like, what? How can the patient? I had the same questions, but those open bites closed drastically fast. And I was not able to believe, but it does close very fast. So when we're talking about these very difficult movements and those residual, I would say orthodontic deformities that we leave post-surgery for us orthodontists to correct, it needs a lot of, that's what I said, it needs a lot of vision. So I had to develop that vision and that, with my training and probably experience. And we are able to close those open bites within like 7 to 8 months. So without any pre-surgical orthodontics. So the patient comes in, we prepare a little bit for a few weeks, and then is ready for the surgery. And after first surgery first, we usually start the orthodontics pretty quick. In some cases, we even put in the TMA wires right before the surgery. So when the patient comes back, we don't have to change the wires. Yeah, there's some brackets that are knocked off, but a lot of things already start moving immediately after surgery. So I would say, give or take, a lot of cases that are done in Chang and my own cases after that take 13 to maximum 18 months from start to finish. Yeah.
Right. How about TMD? Many symmetry cases, patients had a symptom of TMD. So this is second concern. So after surgery, surgery first. How about the TMD? There's some, I don't know, there's some evidence, some TMDs on the residual asymmetry between surgery first and conventional surgery technique. I don't know. But do you have any evidence about that?
Well, for TMD, I was trained not to think too much about it. We do the evaluations and everything. We make a note about it, and a lot of evidence also exists that TMD would come after you do these kind of surgical movements. So there is no stable or no evidence as such which can correlate these two things, that does TMD get alleviated after surgery and orthodontic treatment, or TMD comes after the surgical and orthodontic. There are so many cases that are on both sides of the coin. So for us, we do take a note of that. A lot of times, in my personal cases, I do deprogramming splints for 2 to 3 months maximum, and see where we are going. If the patient's improving, it's good. If no, then we still go ahead and do the surgery first, because at the end of the day, there is no correlation that surgery is going to put the TMJ in the right position. And a lot of cases do end up, after the treatment, but those cases are very minimal, let's say only 4 to 5%. So I look at the benefit and, risk ratio. So just for 4 to 5% patients, I cannot deny the treatment to the rest of the group. So that is my thought about it.
Okay, thank you. I got a lot of advice from this seminar. And normally I try to remove the vapor, I remove the vapor only 3 weeks after surgery,
Right.
in my older cases, because yeah, so after this meeting, I just meet my colleague in the oral surgeons, but their first concern is TMD. I don't know, they concern about TMD. So this is why they very prefer to IVRs, even in the surgery first case. So I don't know, have you done for the surgery first cases with IVRO instead of SSRO?
I don't think so. I have any cases.
Yes.
Most of us we do the BSSO and a lot of rotations for maxillomandibular complex to solve these problems. But IVRO, I'm not really aware of any cases that I have personally done.
So the best benefit of IVRO is just relieve the condyle as their natural position. So this is pretty good. Most of case their TMDs disappear. But you are right, is time treatment duration, I think longer than your surgery first, right?
So, Dr. Cha, I have a question for you. Are there any quantifiable thresholds for residual asymmetry in the 3D simulation that you do before the orthodontic decompensation that correlates with patient-reported satisfaction or the need for revision surgery later on? Like how much of the deformity, let's say if it's more than 5-6 millimeters, how much of the deformity can you actually leave for you to make sure that there is no relapse and you'll be able to correct it with orthodontics later on? Are there any quantifiable thresholds that you use?
How can you correct as orthodontist after surgery? You cannot do anything, as a surgeon. No, surgeon, they can. We just look at the midline deviation, right? After surgery. Yeah, midline deviation after surgery, we can correct. But with this correction, doesn't affect the chin point deviation. So it's a relapse. There's many reasons, Maybe Ellen Go she's expert for the study on the relapse after surgery, I know. So maybe these things is maybe answered by Dr. Go instead of me. Right. Yeah.
All right. Because for some of our cases where we know that the surgical movements are going to be unstable, after the advent of TADS, we are able to stretch that envelope of orthodontic treatment even more, I guess. So a lot of movements that surgical surgeons would not feel, safe, we'd say, okay, you do, 60%, I would do 40%. So a lot of times, like my mentor, Dr. Eric Liu, I would say, I should not say something like this about my own teacher, but he's one of the most craziest orthodontists on the planet, I guess. And there's nothing he won't try that anybody else would even think of. So he's right now kind of correcting the occlusal planes. He's been working on that for decades, I guess, with his, yin yang wires and all that. Well, one thing that I learned from his was, correcting the occlusal cants using TADS by pushing down one side and pulling up the other side. I think that helps the surgeon a lot for them to think that, oh, if this surgical movement is not going to be stable, maybe Eric Liu can do it, but not anybody else, I guess. I'm not sure if you are doing anything of that sort. I would like to know.
Okay. Yeah. Yeah. So,
like,
I
are
think,
you guys using some cantilever arms hooked onto the TADS or heavy elastics to manipulate the occlusion?
you're right. Yeah. We use the conventional techniques for the decompensations. It's been described in my presentation. I introduced some minuscule applications, right? But the stability is, I have still concerns. So impaction is stable, but extrusion is not stable as much as intrusion. So, but yeah, Eric, he showed a wonderful case. So maybe I have to change my mind. So during the pre-surgical orthodontic treatment, we have to look at the envelope of discrepancy. You are right. So this is why if you do surgical simulation by 3D, we can see the envelope very clearly. So we can do correct by orthodontically, but there's a limitation of the envelope. Maybe you have to supported by surgeon, especially Erlangen suggests instead of orthodontic treatments, we can do apical osteotomy instead of the ortho treatment. So it's a better advice. So yeah, we are very late. So any other conversation or discussion? Just some.
I'm here. Thank you.
Yeah, thank you.
Thank you, Professor Navdeep. Last but not least, I'd like to invite Professor Warutka.
Hi, Dr. Shah.
Nice to meet you. Hi.
Hi. Thank you for your lecture. Your case is very fantastic. I like that. Me as the surgeon in my center, I would like to share some experience with surgeon because my center do only the BSSRO, even in the asymmetry case. In our technique, we use like, okay, we cut the BSSRO and then we like cut the posterior of the distal segment to remove the bony interference. Yeah, this is our technique. And okay, come with my question. I have some question about the software. So which software do you use to registration the occlusion with the
Oh, I think
does
Professor.
it's Dolphin, right?
I introduced in vivo software. Yeah, in vivo. Yeah, it's not a Dolphin. Yeah, I use Dolphin, but their license annual license, right? But the in vivo is you don't need to pay annual license, just buy it. So this is why. So very simple. The superimpositions of the model to the CBCT. It's very simple, and manipulation of the surgical corrections is very easy. So, but we have the segmentation of the maxillar mandible separately, and we can change it of the maxillar by translation or rotations. Mandible same. So this is not very precise, but at least for the orthodontist, we can see the skeletal discrepancy after correction of the asymmetry. So this is very simple, right?
And before you like planning the skeleton or the teeth, it need to like set the head position, right? So which landmark do you use to set that position? Because
yeah. CBCT, the head posture is not critical because we use the mid-sagittal plans. We just define it's from CBCT is sellar, nasion, anus. This is mid-sagittal. If the patient has a no cranial base deformity, our reference is mid-sagittal plan. And based on mid-sagittal plan, with perpendicular horizontal plan, orbitale, right, and the right side porium, okay, not both sides, only right side and the left orbitale. So we define horizontal plane. So based on two plane, we define the mandibular asymmetry. Yeah, sometimes we modify, but this is our protocol, mid-sagittal by CBC data.
And what about the hemifacial microsomia, your third case? How you said that?
This is this some cases you have to we have to modify our references. Yeah, then first instead of mid-sagittal plan, we choose the horizontal plan first, then perpendicular reference plane we made. So we opposite protocol sometimes. So we decide horizontal or mid-sagittal based on patient skeletal. Yeah.
And I'm not sure, do you have any experience with the like face scan to superimpose on it?
Face scan. Do you have a face scanner? Face scanner.
Yeah.
But this face scanner, we just collecting data, but unfortunately, we don't make some outcome yet. We just collecting data. So we don't have any like some result yet. So what your major question for the facial scan? Do you have any good idea?
In my center, when you like do the surgical simulation to present with your patient, sometimes we use their real face, the real patient face that scan on the software, because it's easier to understand that, okay, that is your skeleton and your teeth. And after that, your face is like this. Really very easy to communicate with the patient if you the facial scan. And sometimes we used to like measure some interpupil or something like that on the computer.
All right. A good idea. Yeah, good advice. Yeah, for the communication, is color is much more friendly, right? Instead of the gray color, yellow or brown color, right? Yeah.
Okay. Oh, that is my last question. Thank you very much, Dr. Shah. Very good presentation.
Thank you, Professor Waruta, for your questions. And thank you to all our panelists for the questions. Now we'll go on and proceed to our Q&A session. Our first question is from Professor Hari Krishnan, and the question is, for mandible surgeries, if the surgical yaw rotation is a little bit more, would it create fixation problems due to the gap openings between the segments?
Right. This is why our institute we don't do any fixation of the mandible. We just lamest osteotomy. So this is different from the SSRO. So maybe this question be answered by other panel because our institute don't do any fixation. So IBR is very helpful in this situation. So yeah, it's my answer. Yeah, we don't fixations, so we just leave it. And mandible and condyle, their two segments is physiologically remodeled. So very critical for the physical exercise after surgery. So for the 3 weeks, patient has to be very, very strong physical exercise with the elastic. So after 3 weeks, we remove the splint. Then the patient starting the soft diet. So the healing process is very fast. So this is my answer.
Okay, and then that leads to our second question by Dr. Fong. The question is, in the hemifacial microsomia case that you showed us, there was screws on the mandibular body. So, what's the purpose of the mandibular screws? Are those for fixating peak implants?
Right.
Oh, so you actually put in implants to correct the soft tissue defect.
Right, Medipore, yeah. Because insufficient soft tissue and muscle, yeah, there's surgeon they apply implants with the Medipore, yeah, with the mini screw, right?
Okay. And then you also just mentioned that you don't use IMF, you use elastics, and then you keep them on for 3 weeks and then remove them afterwards.
Yeah, the IVL is whole day elastic 3 weeks, and after 3 weeks, patients still wear elastics, but we change light forces and 12 hours. So yeah, some cases we extend the 4 weeks for the full-time wearing of elastic, but after that we reduce the time. So after 2 weeks later, after operations, yeah, most of case only during night. Yeah.
No. And then for your cases, what's the average post-op surgical orthodontic treatment till the time of debonding?
I'm working at the institute. Yeah, some cases is driven by our graduate students. So most of cases 1 year after surgery. Yeah, some cases less than 1 year, but most of cases 1 year. So total treatment is non-extraction cases is 16 to 12, 24 months. Yeah.
Okay, and our last question is from Dr. Harrell, and then the question is, in surgical first approach, how do you stabilize the malocclusion that exists after the surgery? Do you use a splint to help with the stabilization, or do you use other methods?
Yeah, we wear the wafer long time, more than 2 months. So 1 month is the splint fixed with a wire, and after 1 month, we change it by comfortable type of the splint wafer. So yeah, we still ask the patient wear the 2 months more, and the same during the post-surgery treatments. We grinding some wafer to allow the tooth movements is very similar. But during that time, the patient has to wear elastics more than 12 hours. So because there's no fixation. So elastic exercise very important. So some patients fail. Yeah, we have to very concerned about that. Yeah, for the surgery first. Yeah. But my colleagues very good cases, many cases for the surgery first. But for me, I'm only for the very minimum asymmetry patients. Yeah.
Thank you, Professor Cha, for your very comprehensive presentation. I have the last questions. In your experience, you show lots of very good demonstration of facial asymmetry with the two-jaw surgery. And I just wondering, what is the scenario in your cases you will refer a patient to see or to manage the TMD problem prior to the two-jaw surgery? I know the IVL probably is not really huge praise for the condyle. However, is the TMD problem will be your one critical point when you do the orthodontic work before the jaw surgery. Yeah, thank you. In facial asymmetry case, yeah.
TMD? The concern for TMD, the TMD is very complex, the reasons, right? There's muscle problems or condyle problem or disc problem. But in many cases, the patient with the mandibular asymmetry, the patient have a symptom of TMD. We refer the oral medicine first. There's a disc inflammation or not, right? So we have to first control of the pain. That's it, because we re-evaluate after surgery. Because after making the symmetric mandibular positions, we evaluate of the condyle and TMD. So interestingly, we just pain control, but after surgery, most of pain was disappeared by the surgical approach. But if you fail, then we re-diagnosis of the condyle, and we discuss with the oral medicines, and then I know these cases, most cases, I'm concerned about the change of the mandible during the TMD therapy. But in my cases, I haven't seen that kind of cases before. So this is why the mandibular asymmetry patient, especially class 3, the TMDs are major issue is from the asymmetry. So if you released that issue, TMD is, I think, easily to manage it as a orthodontist, also dentist. That's my answer. Yeah.
Thank you very, very much, Professor Cha, and your algorithm and to treat the facial symmetry using digital and very advanced image assistance, including the combined CT and oral scanning, is quite fancy. Yeah, and before I take the group photo, Professor Waruta would like to add an advertisement for the Thai and the Europe orthodontic conferences. So probably Waruta, please.
Okay.
You can share, please.
Okay. You see my poster?
Yes. Yeah, we see
Okay.
clearly.
Thank you very much. Thank you very much, ICC webinar, for invited me to announcement the 7th Asia Euro Symposium. This symposium is about the TMJ and related musculoskeletal disease. We set up on 29 June to July the 1st this year. We have the cadaveric workshop to TMJ lavage or the surgery. And also we have the live surgery. And of course, we have the lecture from around the world. Like our from China and the staff from Germany to join us in this symposium. Okay, if you want more information about this symposium, I suggest you to follow up us in our page. This page is CEMU Dent, and this page is our department page, Oral and Maxillofacial Surgery, Mahidol. Okay, thank you very much.
Thank you, and welcome for our participant to join these conferences. We'd like to invite all our participants. You can turn on your screen, please. And we take a group photo. And I would like to announce that 3 weeks later, we have our next ICC webinar. We invite Professor Chang from the Nice People Hospital in Shanghai, Professor Chang, to share the distraction osteogenesis in cleft deformity with the Shanghai experience. So that could be a very amazing topic to treat the cleft patients. And I would like to count to 3 and please show you a smile. Okay, and we are so privileged and blessed to have the webinar here. And 1, 2, 3, cheers. Okay, thank you so much for your very good sum up. Thank you, Professor Cha. It's very late in Korea now. And thank you, Professor Nadeep. It's very early morning in Alabama now. Good morning and good evening for all your coming to join these conferences. And thank you for all our panelists, Professor Ellen Ko, Professor Waruta, and Professor Nadeep. And prior, would you like to give us some closing remark for all the inviting speakers and the panelists? Please.
Yeah, thank you all for joining this webinar. I think everyone learns about the pre-surgical planning for the surgical cases. And thank you so much for Professor Shah for your insight to share in our presentation in the presentations, and I hope maybe we can learn from you more about the 3D digital orthodontics, because I guess you might work on something for the digital orthodontics, isn't it? Can you share something about that? I just guess, but I hope I can see you like I can see you again at some meetings, and also all the panelists as well. And thank you. Yeah.
Okay.
Yeah, thank you so much. And see you 3 weeks later, and have a good one. Thank you, Professor Cha.
Thank you,
Thank you.
Professor
Have a
Cha.
good one.
And
Thank you,
morning.
Alango.
yeah, see you.
Bye-bye.
Bye-bye.
Yeah, thank you,
Bye-bye.
Kazen-san. Yeah.
Thank you.
Thank you.
Thank you,
감사합니다.
Oh, thank
See you.
you,
감사합니다.
Professor
Professor
Bill
Fayaz.
from
Yes,
Japan.
Hi.
No
Professor
problem.
Low,
Yeah.
thank you.
Yeah.
Okay, thank you, Tatsuo, Professor Liu.
Yeah. And
Bye-bye.
thank you, Professor Bill Harrell as well from the US. I saw he
Thank you,
died.
Professor
Yeah,
Preet.
thank you. Yeah. Thank you, Professor Shah.
Yeah. Bye. Good night.
Yeah, good night. Good
Yeah,
night.
good
Have a good
night.
night.
Yeah.
Yeah.
Good night. Okay, bye-bye.
Bye.